public health research, we often want to answer questions like, does a treatment work? Does an exposure increase risk? Does an intervention improve outcomes? But here's the challenge. Most real-world data is observational, not randomized. This means groups may differ in important ways before treatment even begins, and that leads to bias. In this video, we'll learn how to address this using propensity score matching. Does having health insurance actually lead to better health outcomes? It sounds like a simple question, but in the real world, the data is messy. People with insurance are often different from those without it. They might be older, have higher incomes, or more education. If we just compare them directly, we aren't measuring the effect of insurance. We're measuring the effect of privilege. Today, we're using propensity score matching, PSM, to fix that. We'll be using the 2024 BRFSS dataset, one of the world's largest health surveys, to see if we can create a fair comparison between these two groups. We begin by loading the required R packages. Tidyverse for data cleaning, summaries, and visualization, the Matchit package for performing propensity score matching, and Cobalt to evaluate whether the matching process successfully balanced the comparison groups. Together with these tools, we will create a workflow for reproducible epidemiologic analysis. Next, we load a cleaned BRFSS dataset. We import the file into R and store it as a data frame named DF. At this point, we now have a dataset where each row likely represents one survey participant and each column represents variables such as insurance status, health outcomes, age, income, and employment. Before we begin any analysis, we first inspect the structure of the dataset using the str function. This allows us to verify variable names, data types, and the overall structure of the data. This step is important because variables imported from CSV files are often assigned incorrect formats. We can see that the dataset contains 102,991 observations and 8 variables. That means we have information from more than 100,000 survey participants, which gives us a large sample for analysis. Each row represents one individual respondent, while each column represents a survey variable collected from that participant. Next, we examine the variables themselves. The insurance variable is currently stored as a character variable shown by THR. The values include categories such as insured and not insured. The health variable is also stored as character data and contains categories such as excellent, very good, good, fair, and poor. The age variable contains grouped age categories like 50 to 54, 70 to 74, and 80 plus. Sex is also stored as character data with categories such as male and female. Income contains grouped income categories, for example, less than $10,000, $15,000 to less than $20,000, and $35,000 to less than $50,000. Education includes categories describing educational attainment, such as graduated college or technical school. Employment contains employment categories like employed for wages or retired. Finally, poor underscore health is stored as an integer variable coded as 0 or 1. Because this variable is binary, 0 indicates the respondent did not report poor health, while 1 indicates the respondent did report poor health. And at this stage, many variables are still stored as plain character variables. That creates a problem because statistical models and matching procedures need categorical variables to be stored as factors. So next, we begin transforming the dataset into a format suitable for analysis. Using the mutate function from Tidyverse, we convert several variables into factors. First, we convert insurance into a factor variable. This tells R that insurance status represents categories rather than free text. Next, we convert the health variable into an ordered factor. This step is especially important because health categories have a natural ranking. For example, excellent health is better than very good. Very good is better than good, and so on down to poor health. By specifying the exact order of these categories, we preserve the ordinal structure of the variable. This becomes important later if we perform analyses involving ordered outcomes. Next, we convert age into a factor variable. Although age groups appear numeric in some datasets, these values actually represent categories rather than continuous measurements. For example, 50 to 54 is a category, not a precise age. We also convert sex, income, education, and employment into factors. This ensures that R correctly interprets them as categorical variables during modeling and propensity score matching. Without this step, R might incorrectly treat some variables as continuous numeric values, leading to inaccurate results. Finally, we change the reference category for the insurance variable using the relevel function. We set not insured as the reference group. This step is important because future regression models will compare insured respondents directly against uninsured respondents. As a result, the coefficients and odds ratios we estimate later will describe how insurance status changes the likelihood of poor health relative to people without insurance. And after preparing the variables, we begin performing initial quality checks on the dataset. First, we run the summary function to generate descriptive statistics and frequency summaries for all variables. This gives us an overall snapshot of the dataset and helps us identify unusual distributions or coding problems. We begin with insurance status. The summary shows that 92,205 respondents are insured, while 10,786 respondents are not insured. This immediately tells us that the dataset is heavily weighted toward insured individuals. That imbalance becomes important later during propensity score matching because we will have far more treated observations than control observations. Next, we examine the self-rated health variable. Respondents rated their health across 5 ordered categories: excellent, very good, good, fair, and poor. Overall, this distribution suggests that most respondents rate their health somewhere in the middle categories rather than at the extremes. Next, we look at the age distribution. The dataset contains respondents across multiple age groups. The largest age category is 65 to 69 years old, followed closely by 60 to 64. We also see a substantial number of younger adults, including respondents aged 18 to 24. Overall, the age distribution suggests that the dataset includes a relatively older population, with many respondents concentrated in retirement age categories. Next, we examine sex. The sample is fairly balanced between males and females. This near balance is helpful because it reduces the likelihood of major sex-based sampling imbalance in the analysis. Next, we move to income categories. The largest income category is $25,000 to less than $35,000, with more than 25,000 respondents. Relatively fewer respondents appear in higher income groups, such as $50,000 to less than $75,000. Overall, this distribution suggests the sample contains many lower and middle income respondents. Next, we examine educational attainment. Most respondents report graduating from college or technical school. Far fewer respondents report lower levels of educational attainment, such as not graduating high school. This indicates that the dataset is heavily concentrated among individuals with higher educational levels. Next, we review employment status. The largest employment category is employed for wages, with more than 38,000 respondents. The second largest category is retired, with over 30,000 respondents. This aligns with the older age distribution we observed earlier. We also see groups representing individuals unable to work, self-employed respondents, homemakers, and unemployed individuals. Together, these categories provide important socioeconomic context that may influence both insurance coverage and health outcomes. Finally, we examine the poor underscore health variable. This variable is binary, coded as either 0 or 1. The mean is approximately 0.286. Since this is a binary variable, the mean represents the proportion of respondents reporting poor health. In other words, about 28.5% of respondents in the dataset report poor health outcomes. The median is 0, which tells us that more than half of respondents do not report poor health. Overall, these summary statistics provide an important descriptive snapshot of the dataset before we begin causal inference analysis. Next, we display the first several rows of the dataset using the head function. Viewing the raw observations allows us to visually confirm that variables imported and transformed correctly. Next, we check for missing values across all variables using the colsums function combined with is.na. The results show zeros across every column. This is important because it tells us the dataset is completely clean with respect to missing data for these variables. That means we do not need to remove incomplete observations, we do not need to impute missing values, and we can proceed directly into statistical modeling or analysis with confidence that all records contain complete information. Now we perform the first actual analysis. We start with what we call a naive comparison between insurance status and poor health outcomes. The goal here is to compare the proportion of people reporting poor health between those with insurance and those without insurance. To do this, the data is grouped by insurance status, and then we calculate the average value of the poor underscore health variable within each group. Because poor underscore health is coded as 0 and 1. 0 means the respondent did not report poor health, and 1 means they did. When we take the mean of a binary variable like this, the result becomes a proportion or rate. Looking at the results, we see that uninsured respondents have a poor health rate of approximately 0.289. This means that about 28.9% of uninsured individuals report poor health. For insured respondents, the poor health rate is approximately 0.285. That means about 28.5% of insured individuals report poor health. The bar chart visualizes this difference clearly. At first glance, the difference between the two groups appears very small. The uninsured group shows only a slightly higher rate of poor health compared with the insured group. We also see the sample sizes for each group. The uninsured category contains 10,786 respondents, while the insured category contains 92,205 respondents. Again, this highlights the major imbalance in group sizes within the dataset. At this point, it is important to emphasize that this comparison is completely unadjusted. We have not yet accounted for important confounding variables such as age, income, education, sex, or employment status. As a result, we cannot interpret these raw differences as causal effects. For example, insured respondents may differ systematically from uninsured respondents in ways that influence health outcomes independently of insurance coverage itself. Older adults may be more likely to have insurance. Higher income individuals may also have greater access to healthcare and better underlying health status. Without adjustment, these factors can distort the observed relationship between insurance and poor health. This is exactly why we move next into propensity score matching. Matching helps us create more comparable groups so that differences in poor health outcomes are less influenced by observable demographic and socioeconomic differences. Before matching begins, we set a random seed using set.seed42. This ensures reproducibility, meaning anyone running the code again should obtain the same matching results. Next, we create a propensity score model using the matchIt function. In this analysis, insurance status serves as the treatment variable. We estimate each participant's probability of being insured based on several covariates, including age, sex, income, education, and employment status. These estimated probabilities are called propensity scores. Next, we perform nearest neighbor matching. This method pairs each insured respondent with the uninsured respondent who has the closest propensity score. We specify 1-to-1 matching using a ratio of 1. We also disable replacement, meaning each uninsured respondent can only be matched once. In addition, we apply a caliper of 0.2. The caliper restricts matches to respondents with sufficiently similar propensity scores and helps prevent poor quality matches. After fitting the propensity score model, we generate a matching summary. This summary allows us to evaluate covariate balance, propensity score overlap, and sample sizes before and after matching. This output is one of the most important parts of the analysis because it tells us whether the matching process successfully reduced differences between insured and uninsured respondents. Notice the warning message at the top: fewer control units than treated units. This means there are far more insured people than uninsured people in the dataset. As a result, not every insured person can be matched to an uninsured counterpart. That's why many treated observations remain unmatched. At the very top, we see the exact matching procedure that we specified in the match it function. We matched insurance status using several covariates: age, sex, income, education, and employment. We used nearest neighbor matching with one-to-one matching, no replacement, and a caliper of 0.2. This means each insured respondent was paired with the uninsured respondent who had the closest propensity score, as long as the difference between scores remained within the caliper threshold. Next, we move into the section called Summary of Balance for All Data. This section describes imbalance before matching. In other words, it shows how different insured and uninsured respondents were before any adjustment took place. We first look at the propensity score distance measure. The mean propensity score among insured respondents is approximately 0.914, while the mean among uninsured respondents is about 0.735. That difference is extremely large. The standardized mean difference for the distance measure is 1.63. This immediately tells us that the two groups were highly different before matching. A standardized mean difference above 0.1 generally indicates meaningful imbalance, so a value above 1.6 reflects very severe imbalance. Next, we examine the age categories. Before matching, uninsured respondents were much younger on average. For example, respondents aged 18 to 24, 25 to 29, and 30 to 34 appear more frequently among the uninsured group. Meanwhile, older age categories such as 65 to 69, 70 to 74, 75 to 79, and 80 plus appear much more frequently among insured respondents. This pattern makes intuitive sense because older adults are more likely to qualify for programs such as Medicare and therefore have insurance coverage. We can see this imbalance clearly in the standardized mean differences. Several older age groups show values above 0.3 before matching, indicating substantial differences between groups. Next, we examine sex. Before matching, the insured group contains a higher proportion of females, while the uninsured group contains more males. The standardized mean difference is about 0.20, again indicating notable imbalance. And income also shows important differences before matching. Lower income categories appear more common among uninsured respondents, while some middle and higher income categories appear more common among insured respondents. Several income categories show standardized mean differences greater than 0.15 or 0.20. This suggests that income is strongly associated with insurance status in the raw dataset. Education displays even larger imbalances. For example, the category representing college or technical school graduates shows a very large standardized mean difference above 0.60. Meanwhile, high school graduates appear much more common among uninsured respondents. This indicates that educational attainment differs substantially between the two groups before adjustment. Employment status also shows major imbalance. For example, retired individuals are far more common among insured respondents. The standardized mean difference for retirement status is approximately 0.64, which is extremely large. This again reflects the relationship between older age and insurance coverage. On the other hand, categories such as self-employed or unemployed appear more common among uninsured respondents. Overall, this first section confirms that insured and uninsured respondents are very different before matching. Without adjustment, comparing health outcomes between these groups would likely produce biased estimates because the groups differ across many demographic and socioeconomic characteristics. Next, we move to the section called Summary of Balance for Matched Data. This section shows what happened after propensity score matching. Our goal here is to determine whether the matching process reduced imbalance across covariates. The first thing we notice is that the standardized mean difference for the propensity score distance dropped dramatically. Before matching, it was approximately 1.63. After matching, it falls to about 0.21. That represents a major improvement in overall balance between groups. Next, we examine the age categories again. Most of the age-related imbalances decrease substantially after matching. For example, age 18 to 24, age 45 to 49, and age 65 to 69 all move much closer to zero. Many age categories now fall below the common 0.1 threshold for acceptable balance. However, some moderate imbalance still remains in certain middle age categories such as 25 to 29, 30 to 34, and 40 to 44. So while balance improved considerably, matching did not eliminate all differences completely. Next, we examine sex. The standardized mean difference decreases from about 0.20 to approximately 0.14. This represents improvement, although some residual imbalance still remains. Income categories also improve substantially after matching. Most standardized mean differences become smaller and move closer to zero. Several income categories now fall within or near acceptable balance thresholds. Education imbalance also decreases noticeably. The very large imbalance we observed earlier among college graduates becomes much smaller after matching. Employment status improves as well, although some employment categories still show residual imbalance. For example, the category employed for wages still has a standardized mean difference around 0.39 after matching. That tells us employment remains one of the more difficult variables to fully balance in this dataset. Next, we look at the ECDF statistics. These values measure differences in the overall distribution of covariates between groups. Smaller values indicate better overlap after matching. In general, the ECDF measures improve substantially after matching, which suggests that the treated and control groups became much more comparable. We also see a column labeled standard pair distance. This statistic measures within-pair similarity between matched individuals. Smaller values indicate closer matches between treated and control respondents. Finally, we examine the sample sizes. Before matching, the dataset contained 92,205 insured respondents and 10,786 uninsured respondents. After matching, we retain 10,565 insured respondents and 10,565 uninsured respondents. This means the final matched sample is perfectly balanced in terms of group size. However, we also see that more than 81,000 insured respondents remained unmatched and were excluded from the final matched analysis. This is one of the major trade-offs of propensity score matching. We sacrifice sample size in exchange for better comparability between groups. In other words, we intentionally remove observations that do not have suitable matches so that the remaining groups become more similar on observable characteristics. To get a better understanding of our results, we present it visually using a love plot. This figure shows the covariate balance before and after propensity score matching using standardized mean differences, or SMDs. The red points represent the unadjusted sample, meaning before matching, while the blue points represent the adjusted sample after matching. The vertical dashed line at 0.1 is important because it represents the commonly accepted threshold for adequate balance. Variables with standardized mean differences below zero point 0.1 are generally considered well balanced between the insured and uninsured groups. Before matching, several variables showed substantial imbalance. For example, some age categories, employment categories, and education variables had relatively large standardized mean differences, indicating that the insured and uninsured groups were quite different in their baseline characteristics. After matching, we can see that the blue points move much closer to zero for nearly all covariates. Most variables are now below the zero point 0.1 threshold, suggesting that the matching procedure substantially improved covariate balance. This is exactly what propensity score matching is designed to do: create treatment and comparison groups that are more similar with respect to observed characteristics. However, we also notice that a few variables still show mild residual imbalance after matching. While this is common in real world data, it reminds us that matching improves comparability, but may not produce perfect equivalence across all covariates. Overall, this balance plot suggests that the propensity score matching procedure performed well and successfully reduced systematic differences between the groups, making subsequent treatment effect estimates more credible and less confounded by measured variables. Next, we visualize the distribution of propensity scores. First, we generate histograms showing propensity score distributions before and after matching. These plots help us assess overlap between treated and control groups. Good overlap indicates that insured and uninsured respondents share similar observable characteristics and can reasonably be compared. Let's start with the top left panel labeled raw treated. This shows the distribution of propensity scores for the insured group before matching. Most insured participants have very high propensity scores clustered close to 1.0. In other words, based on their demographic and socioeconomic characteristics, the model predicted that these individuals were very likely to have insurance. Now compare that to the bottom left panel labeled raw control. This represents the uninsured group before matching. Their propensity scores are much more spread out and generally lower. This tells us the uninsured participants looked systematically different from the insured participants even before we analyzed health outcomes. This imbalance is exactly why causal inference methods like propensity score matching are necessary. If we compared these groups directly, we could easily mistake demographic differences for an insurance effect. After matching, we move to the right side of the figure. The top right panel shows the matched insured participants. Notice that the distribution becomes much wider and less concentrated near 1.0. That means the matching algorithm selected insured individuals who more closely resembled the uninsured participants. Now look at the bottom right panel showing the matched uninsured group. The shape of this distribution now looks much more similar to the matched insured group. This increased overlap between the two distributions is a good sign. It suggests that the matching process successfully created more comparable groups based on the observed covariates. In practical terms, we are reducing confounding. Instead of comparing people with completely different socioeconomic and demographic profiles, we are now comparing participants who look more alike on measured characteristics. However, we should also notice that the overlap is not perfect. Some differences still remain, particularly at the higher propensity score ranges. This tells us that certain insured individuals still had no close uninsured equivalent available for matching. That observation also helps explain why so many treated observations remained unmatched in the earlier output. The insured group was extremely large and fundamentally different from the uninsured group in several ways, so the algorithm could only retain participants with sufficient common support. Overall, these histograms show that matching substantially improved comparability between the groups, even though some residual imbalance still exists. This gives us greater confidence that any post-matching differences in health outcomes are less likely to be driven entirely by measured confounding variables. We also generate density plots, which provide a smoother visualization of propensity score overlap. Looking at the plots, the left panel shows the original unmatched data, while the right panel shows the matched sample. Before matching, the insured and uninsured groups differed substantially across age, sex, income, education, and employment. For example, insured participants were generally older, had higher income and education levels, and were more likely to be retired. These differences are important because they can influence both insurance status and health outcomes, creating confounding bias. After matching, the distributions across most variables became much more similar, indicating improved balance between the groups. Although some imbalance remained, particularly for employment, the matching procedure substantially reduced differences in observed characteristics. Overall, the plots demonstrate that propensity score matching improved comparability between insured and uninsured participants, strengthening the credibility of the analysis. Since we have confirmed acceptable matching quality, we now extract the matched sample into a new dataset called matched_DF. Next, we compare poor health rates before matching and after matching. Before matching, differences between groups may partly reflect demographic and socioeconomic inequalities. After matching, we create a more controlled comparison because the participants now resemble one another more closely. For the post-matching analysis, we use weights generated during the matching process. These weights help us account for how each participant contributes to the matched sample. Finally, we visualize both sets of results side by side. This visualization makes public health communication much easier because audiences can immediately see how statistical adjustment changes the estimated association. Sometimes the difference shrinks substantially after matching, which suggests that confounding variables explain part of the original relationship. Now let's look at the chart comparing poor health rates between uninsured and insured individuals before and after propensity score matching. Starting with the uninsured group on the left, the poor health rate remains almost identical before and after matching at approximately 28.9%. This indicates that the matching process had a little effect on the composition of the uninsured group. Now, looking at the insured group on the right, we see a different pattern. Before matching, the poor health rate among insured individuals was about 28.5%, but after matching, it increases to approximately 31.2%. This suggests that the matching process changed the composition of the insured group in an important way. Why would this happen? Before matching, the insured population may have included many relatively healthy individuals alongside higher risk individuals. After matching, the algorithm selected insured individuals who were more comparable to the uninsured group based on age, sex, income, education, and employment status. As a result, the matched insured sample appears to contain a higher concentration of individuals reporting poor health. This highlights an important concept in propensity score matching. Matching can substantially alter the analytic sample. The goal is not to preserve the original sample distribution, but rather to create groups that are more comparable on observed covariates. So the increase in poor health after matching does not mean that matching worsened health outcomes. Instead, it reflects the re-weighting and selection process used to improve balance between the groups. Importantly, even after matching, the insured group still shows a somewhat higher poor health rate than the uninsured group. This may reflect residual confounding healthcare seeking behavior or the possibility that individuals in poor health are more likely to obtain or maintain insurance coverage. Overall, this figure demonstrates how propensity score matching can meaningfully change the estimated association by adjusting for differences in baseline characteristics between groups. Finally, we fit a logistic regression model using the matched dataset. The model predicts poor health as a function of insurance status while incorporating matching weights. Because poor health is a binary outcome, logistic regression provides an appropriate method for estimating the association. Next, we summarize the regression results. To improve interpretation, we convert the regression coefficients into odds ratios using the exponential function. Odds ratios are easier to interpret because they describe how insurance status changes the odds of reporting poor health. We also calculate 95% confidence intervals for the odds ratios. Now let's unpack our results. This model estimates the association between insurance status and the odds of reporting poor health after propensity score matching has already balanced the observed covariates. Let's start with the insurance coefficient. The estimate for insured individuals is 0.113, with a highly statistically significant p-value of 0.000166, which tells us that the association is unlikely to be due to random chance. However, logistic regression coefficients are expressed in log odds, which are not very intuitive, so we exponentiate the coefficient to obtain the odds ratio. The odds ratio for insurance is 1.12. This means that after matching, insured individuals have approximately 12% higher odds of reporting poor health compared to uninsured individuals. The 95% confidence interval ranges from 1.06 to 1.19, and importantly, this interval does not include 1, which reinforces that the association is statistically significant. At first, this may seem counterintuitive. We might expect insurance to improve health outcomes, but this result should be interpreted carefully. One likely explanation is reverse causation or health selection. Individuals with poorer health may be more likely to obtain or maintain health insurance because they need more medical care. Another possibility is residual confounding, meaning there may still be unmeasured factors, such as chronic disease burden, disability status, or healthcare utilization, that were not included in the matching model. So while propensity score matching improved comparability between groups, it cannot eliminate all bias from observational data. Looking at model fit, the residual deviance is slightly lower than the null deviance, indicating that insurance explains some variation in poor health, but likely only a modest amount. Overall, this model suggests that insurance status is associated with a slightly higher reported likelihood of poor health in this matched sample. Importantly, this should not be interpreted as insurance causing worse health. Rather, it likely reflects the reality that individuals in poorer health are more likely to be insured, highlighting one of the key challenges in causal inference using observational public health data. We have now come to the end of today's analysis. In this video, we introduced propensity score matching and how it helps us reduce bias in observational data by creating more comparable groups. This is a critical step when working with real-world public health data where randomized experiments are often not possible. In the next videos, we'll expand beyond traditional analysis and explore how these methods connect to modern public health workflows, including machine learning applications, automated reporting, and the creation of interactive dashboards for communicating results and supporting decision-making. Subscribe and stay with the series as we bring everything together into practical, real-world public health analysis using R.